Welcome back to Deep Dive Ortho, where we pull apart complex orthopedic topics to get to the core insights. Today, we're zeroing in on the wrist, an absolute engineering marvel, isn't it? So intricate, allowing incredible precision, yet incredibly vulnerable to some truly devastating injuries. Our focus for this deep dive is on radiocarpal fracture dislocations. These are far beyond your everyday sprains or simple breaks. They're uncommon, yes, but when they do occur, the impact on a patient's life, their function, their future, well, it can be profound and long lasting. Our mission today is to truly unpack the intricacies of these severe injuries. We'll explore everything from the subtle diagnostic clues that can be missed to the sophisticated surgical strategies and the long term realities for these patients. We're aiming for a comprehensive, nuanced understanding tailored specifically for you, our mid senior medical professionals who often face these challenging cases. To guide us through this complex anatomical and clinical landscape, we're honored to have our expert guest with us today.
Thank you. It's a pleasure to be here. You've hit the nail on the head. Radiocarpal fracture dislocations are, without question, at the more severe end of the wrist injury spectrum. They almost invariably result from high-energy trauma, and their potential for significant, even permanent functional impairment means that a truly deep understanding is absolutely crucial. It's not just about fixing a bone. It's about meticulous planning and execution, really, to preserve a patient's long-term quality of life.
Absolutely, and that meticulous approach begins right at the foundation. When we talk about such profound disruptions, it always circles back to the anatomical foundation. This injury is so devastating because of how perfectly engineered the wrist is. Could you start us off by reminding us of its critical components, especially those that bear the brunt of these forces?
Of course. Yes, to appreciate the scale of disruption in these injuries, we must first briefly recap the wrist's intricate architecture. At its core, we have the radiocarpal joint. It's the primary articulation where the distal end of the radius, along with its crucial articular disc, meets three key bones of the proximal carpus: the scaphoid, the lunate, and the triquetral. Functionally, it's classified as a synovial ellipsoid joint, which is what grants the wrist its incredible range of two-axis movement, flexion, extension, and abduction. It's vital to remember the radius directly articulates with the scaphoid and lunate, while its connection to the triquetral is indirect, through that biconcave articular disc. And that disc is actually part of the larger triangular fibrocartilaginous complex, the TFCC. Adjacent to this, and equally critical, is the distal radial ulnar joint, or DRUJ. This is a synovial pivot joint formed between the ulnar head and the sigmoid notch of the radius. Now here's a truly remarkable insight. While bones obviously provide structure, the osseous components of the DRUJ contribute only about 20% to its overall stability.
Only 20%.
Yes, only about 20%. The vast majority, a staggering 80%, comes from its soft tissues, most notably the triangular fibrocartilaginous complex, or TFCC. This isn't just a simple disc, it's a sophisticated complex that acts as a major stabilizer for both the radiocarpal and ulnocarpal joints. It plays a critical role in preventing the ulna from impacting the carpus, a condition known as ulnocarpal abutment, and critically, it facilitates the complex pronation and supination movements of the forearm and wrist. Its key components include the central articular disc itself, the dorsal and palmar radial ulnar ligaments that tether the radius and ulna, the ulnomeniscal homologue, and the ulnar collateral and ulnocarpal ligaments. You see, even a seemingly minor tear here can lead to profound functional deficits down the line, far beyond what SC's injury alone might cause.
That's a really important point about the TFCC.
It is. Then beyond these primary articulations, we have the intricate arrangement of the 8 carpal bones, organized into 2 rows. These bones, along with a dense network of intrinsic and extrinsic ligaments, function as both static and dynamic stabilizers, enabling the wrist's wide range of movements. From a clinical perspective, in these severe injuries, the intrinsic ligaments of most concern are the scapholunate and lunotriquetral ligaments. Each has dorsal, volar, and interosseous fibrocartilaginous components, and their integrity is paramount to maintaining carpal alignment.
And how do we check that alignment? You mentioned radiographs earlier.
Yes, for assessing carpal alignment on standard radiographs, we heavily rely on what we call the Gilula arcs. When we look at a PA wrist X-ray, we're almost looking for a specific set of curves. Think of it like a finely tuned machine. You expect 3 perfectly smooth concentric arches formed by the carpal bones. The first arc outlines the proximal margin of the proximal carpus, the second outlines its distal margin, and the third outlines the proximal margin of the capitate and hamate. If any of those arcs are broken, jagged, or discontinuous, a loss of congruency, it's a huge red flag. It's a simple visual cue that immediately tells you something is profoundly out of alignment within the carpus, often the first hint of a serious injury.
All right, a break in the pattern.
Exactly. Now, when we discuss the extrinsic ligaments, their role in preventing radiocarpal dislocation is truly paramount. What's truly eye-opening is the sheer biomechanical dominance of the volar capsule ligamentous complex. This complex includes critical structures like the radioscaphocapitate, the long and short radiolunate ligaments, and the pulmar capsule. They are not just supporting players, they are the primary restraint against radiocarpal dislocation. Research demonstrates they contribute a substantial 61% of resistance to dorsal translation and 48% to palmar translation of the carpus.
61% for dorsal, that's huge.
It is. In stark contrast, the dorsal ligaments contribute a minor 2% and 6% respectively under the same conditions. This isn't just a number, it's a direct roadmap for our surgical priorities. Robust repair of these hollow structures and any associated radial styloid fracture isn't an option. It's the absolute non-negotiable cornerstone for restoring stability.
So the volar site is really the key player in preventing dislocation.
Absolutely. Finally, just briefly on innervation and blood supply. The radiocarpal joint receives its nerve supply from articular branches of the anterior interosseous nerve from the median, the posterior interosseous nerve from the radial, and the deep and dorsal branches of the ulnar nerve. Blood supply is primarily from branches of the dorsal and palmar carpal arches. However, for these high-energy injuries, it's a potential for traction neuropraxia to these nerves due to the severe deformity. That's the real clinical concern we must vigilantly monitor.
That foundational understanding of the wrist's intricate design truly highlights how disruptive a radiocarpal fracture dislocation can be. It's like a complex machine suddenly losing its core alignment, especially when you consider how much stability comes from those volar ligaments. Knowing that they are the primary restraints really puts the severity into perspective. So, what does this all mean when we talk about the injury itself? How does such a severe disruption occur, and what exactly defines it, beyond just the general idea of a wrist injury?
You're right to connect the two. The anatomical complexity makes these injuries particularly challenging. To define it precisely, a radiocarpal dislocation, or RCD, refers to the total loss of contact between the carpus and the distal radius. This is a key differentiator from simpler intra-articular shear or rim fractures of the distal radius, where a piece of the articular surface may break off, but the main articular fragment still maintains contact with the carpus. When we speak of a radiocarpal fracture dislocation, or RCFD, we're talking of this total loss of contact along with associated bony fractures. It's a combined injury of both the articulation and bone.
Okay, total loss of contact. And how common are these?
Well, in terms of how often we see these, RCFDs are thankfully rare. They account for only about 0.2% of all wrist injuries annually.
Tiny fraction.
Very small. Epidemiologically, we tend to see them more frequently in males than females, and dorsal dislocations are somewhat more common than volar dislocations. The most significant demographic trend, though, is their strong association with high-energy trauma. These aren't typically simple slips. They demand significant force. We're talking about mechanisms like falls from a significant height, high-speed motor vehicle accidents, or industrial accidents.
Right, serious mechanisms.
Exactly. The typical mechanism of injury involves a high-energy shear or rotational force applied to a wrist that is both hyperextended and pronated. This classic scenario is often described as a fouche injury, a fall on an outstretched hand. The sheer force involved in such an event means that the damage isn't limited to just the bony structures. It also extends to the crucial ligaments and can frequently involve vessels and nerves. It's truly a domino effect of destruction.
A domino effect. That's a good way to put it.
And this brings us to the profound importance of identifying concomitant injuries, as they are exceedingly common with RCFDs. From an orthopedic perspective, we frequently find various types of distal radius fractures, particularly radial styloid avulsion fractures. These are highly significant because they often involve the direct attachment point of the radioscaphocapitate ligament, a primary stabilizer we just discussed.
Ah, back to that key ligament.
Precisely. We also commonly see volar lunate facet fractures, which are where the short radiolunate ligament attaches, and ulnar styloid fractures. Beyond the radius and ulna, other carpal bone fractures are regrettably common, including the scaphoid, lunate trapezium, triquetral hamate, pisiform, and capitate. It's a whole cascade. It's also critical to assess for an irreducible DRUJ, which can occur due to soft tissue interposition, and for intercarpal injuries, such as capholunate or lunotriquetral dissociation, which further complicate the overall stability and long-term prognosis.
And what about nerves and vessels? You mentioned neuropraxia earlier.
Yes, neurological involvement is also a significant concern, often presenting with a patient reporting numbness or weakness. Median nerve injuries are more frequent than ulnar nerve injuries in these cases. These are typically due to a mechanical traction, neuropraxia, where the nerve is stretched or pulled over the deformed wrist during the injury. It's not necessarily a direct laceration, but the nerve is functionally compromised by the extreme distortion of the anatomy. Additionally, radial and ulnar artery injuries are not uncommon due to the severe deformity that occurs, sometimes requiring immediate vascular assessment and potentially repair.
That cascade of associated injuries you mentioned, it really drives home how much is at stake. It's not just a bone break, it's a systemic disruption affecting bones, ligaments, nerves, vessels. Here's where it gets really interesting. The sheer force required and the cascade of associated injuries underscore the critical need for a meticulous approach. So when a patient presents with this level of trauma, how do we, as clinicians, effectively cut through the noise and get a definitive diagnosis? What are your go-to imaging strategies, and what are the critical findings we should be looking for?
Indeed, diagnosis is foundational, and it starts with the most accessible tools. Conventional radiography, or X-ray as it's commonly called, is always the primary radiological investigation for acute wrist trauma. For suspected wrist fractures, it's essential to obtain at least 3 views: the posterior, or PA view, the lateral view, and a 45-degree oblique view. For increased sensitivity, particularly when a scaphoid fracture is suspected given their high incidence in Fuchs injuries, we'll often place the hand in ulnar deviation for the PA scaphoid views, as this elongates the scaphoid bone and can unmask subtle fractures. High-quality radiographs with standardized positioning are key. Poor images can lead to significant misdiagnoses.
Right, good quality views are essential. What are the signs on X-ray?
On the PA view, crucial radiographic signs of a radiocarpal dislocation include a total loss of contact between the carpus and the radius, often with ulnar translation of the carpus and widening of the intercarpal spaces. As we discussed, a clear sign is the disruption of the Jalula arcs, those 3 concentric arcs that define normal carpal alignment, losing their collinearity.
The broken arcs again.
Exactly.
Yeah.
If you see breaks in those smooth curves, it's an immediate red flag. On the lateral view, we look for obvious dorsal or volar radiocarpal wrist dislocation and a loss of collinearity of the lunate with the articular surface of the radius. If there's a lunate dislocation, you'll specifically see what's often referred to as the spilled teacup sign, where the lunate displaces volarly, resembling an overturned teacup.
Ah, the spilled teacup, classic sign.
It is. When evaluating associated discal radius fractures on X-ray, we also measure several parameters that correlate strongly with long-term patient outcomes. These include radial length, normally 11 to 22 millimeters, radial inclination, normally 13 to 30 degrees, and the volar, or dorsal tilt, measured on the lateral view, normally ranges from 4 degrees dorsal to 11 degrees volar tilt. Significant deviations, for example, a decrease in radial length by more than 2 millimeters, a dorsal tilt greater than 20 degrees, or radial inclination less than 10 degrees are all associated with decreased long-term wrist function and alert us to the need for more aggressive intervention. Subtle clues on initial radiographs, such as soft tissue swelling or the obliteration of the pronator quadratus fat stripe, can also hint at a fracture. However, it's important to remember a critical limitation. Approximately 30% of wrist fractures, especially scaphoid fractures, can be radiographically occult on initial X-rays.
30% missed on initial X-ray. That's significant.
It is. A negative X-ray, especially with high clinical suspicion, should never rule out a fracture definitively.
So what's next if the X-ray isn't clear or you suspect more?
This is precisely where computed tomography, or CT, becomes the modality of choice for more detailed evaluation. CT is invaluable for suspected bony injuries, particularly when radiographs are negative or indeterminate. It excels at visualizing complex, comminuted fractures, and, crucially, it allows us to identify and measure intra-articular step-offs, especially those greater than 2 millimeters. We know these strongly correlate with late development of osteoarthritis and typically warrant open reduction and internal fixation to restore articular congruity. CT also provides multiplanar and volumetric reformations, which are incredibly useful for comprehensive preoperative planning, allowing us to virtually reconstruct the injury before we even enter the operating theater.
So CT for the bone detail and planning.
Exactly. It's also superior for detecting subtle, non-displaced scaphoid fractures and other associated carpal injuries that might be missed on conventional X-rays. Furthermore, CT is the gold standard for evaluating DRUJ dislocations, with the epicenter method being the preferred technique for assessing its instability and guiding reduction.
Okay, and where does MRI fit into this picture?
Magnetic resonance imaging, or MRI, has a more limited role in the acute phase of fractures and dislocations due to its availability, time constraints, and cost. However, its critical role lies in evaluating soft tissue injuries, such as damage to tendons, ligaments, and muscles components often severely compromised in these high-energy traumas. It's also excellent for detecting truly occult fractures, particularly trabecular fractures without cortical breach, which CT gonna miss. For instance, a short protocol MRI can be used effectively in the emergency setting specifically for suspected occult scaphoid fractures. Optimized parameters for wrist MRI typically involve an 8-12 centimeter field of view, 3 millimeter slice thickness, and dedicated phased array extremity coils. Sequences like T2-weighted or proton density with fat suppression are ideal for detecting bone marrow edema and fracture lines, while T1-weighted sequences are added for assessing bony alignment. It truly provides the missing pieces of the puzzle when the soft tissue injury is extensive or unclear.
That's a powerful toolkit for diagnosis. It really underscores the importance of choosing the right imaging at the right time to get the full picture, especially when so much can be missed on initial radiographs. It's not just about seeing a break, it's about truly understanding the extent of the damage to both bone and soft tissue. Once we've identified and fully characterized the injury, how do we categorize these complex fracture dislocations? Are there classification systems that help guide prognosis and management?
That's an excellent point, as classification helps us both understand the severity and plan our approach. While we have several classification systems, it's worth briefly acknowledging some of the eponymous distal radius fractures first. For those of you regularly in clinic, terms like Colles fracture or Smith's fracture are second nature.
Very familiar names.
Indeed. They describe specific patterns Colles with dorsal displacement, often from a fall on a dorsiflexed hand, common in older patients with osteoporosis. Smith's, the reverse, with volar displacement, often from higher energy onto a flexed wrist, perhaps in younger individuals. Then there's Barton's fracture, an intra-articular shear fracture with carpal displacement, either volar or dorsal. And the Hutchinson fracture, or chauffeur's fracture, involving the radial styloid, again intra-articular. While these terms are deeply ingrained in practice, their universal reproducibility on radiographs or CT scans is actually quite limited, as studies have shown.
So maybe less reliable than we think.
Potentially. Therefore, when assessing the severity of radial fractures in the context of RCFDs, the most important considerations for us are the precise displacement of the fracture fragments, the extent of intra-articular extension, and any step-off, particularly the DRUJ or radiocarpal joint, the degree of comminution, and critically, the presence of any associated ulnar, other carpal bone, or soft tissue injuries. These factors directly dictate prognosis and the surgical approach, perhaps more than the eponym itself.
Okay, focus on the specifics of the injury pattern rather than just the name. What about classification specifically for the radiocarpal fracture dislocations themselves?
Yes, moving specifically to radiocarpal fracture dislocations, there are a couple of classifications we refer to. The Mooney classification divides these injuries based on the presence of intercarpal involvement. Type 1 injuries are RCFDs without associated intercarpal dissociation. So the dislocation is at the radiocarpal joint, maybe with a radial styloid fracture, but the carpus itself remains intact as a unit. Type 2, on the other hand, involves an RCFD with associated intercarpal dissociation, maybe a carpal bone fracture or an intercarpal ligament tear. This means the injury has propagated further into the carpus.
And does that distinction matter clinically?
It does. It's generally accepted that type 2 injuries are typically more severe and are associated with worse outcomes, often necessitating open reduction and more extensive repair. They demand a heightened level of vigilance.
Right, more complex repair needed.
Then there's the Dumontier classification. This classifies RCFDs into two groups, historically attempting to guide the surgical approach. Type 1 is a purely ligamentous RCFD, or one involving only a small cortical avulsion off the radius. The key here is primary ligamentous failure. Type 2 refers to an RCFD associated with a large radial styloid fracture fragment, involving at least 1/3 of the scaphoid fossa. The implication is the crucial ligaments are attached to that displaced styloid fragment. Historically, this suggested maybe a volar approach for type 1 and dorsal for type 2. However, clinical experience has shown that outcomes varied, and current thinking often requires a more combined, comprehensive approach regardless of this classification to ensure full anatomical restoration.
So the Dumontier type might not dictate the approach as much anymore.
Not rigidly, no. The injury itself dictates the approach needed for full reduction and fixation. Finally, it's also important to consider the Mayfield classification for paralunate instability, as RCFDs can be part of this progressive spectrum, especially with high-energy trauma. This describes a sequential pattern of ligament disruption around the lunate, stage 1, Scapholunate dissociation widening of that interval, a lesser arc injury. Stage 2, paralunate dislocation. The lunate stays aligned with the radius, but the rest of the carpus dislocates, usually dorsally. This is often a greater arc injury, potentially involving fractures like a transscaphoid paralunate dislocation. Stage 3 adds lunotriquetral joint disruption. Stage 4, complete disruption of radiolunate ligaments, allowing the lunate itself to displace volarly, that classic spilled teacup sign again.
The whole carpus sort of unravels sequentially.
Precisely. And it's worth noting that transscaphoid paralunate dislocation is actually the most common pattern of paralunate fracture dislocation we encounter. These stages highlight the extensive damage possible beyond just the primary RCFD, profoundly impacting function if not addressed comprehensively.
So, what does this all mean for the clinician? These classifications, while imperfect perhaps, clearly highlight the need to look beyond the obvious and consider the full spectrum of injury. It's not just a dislocation, it's what else has been disrupted and the sequence of that disruption. Once the injury is thoroughly assessed and classified, the next critical step is management. What are the current approaches, both conservative and operative, and what evidence guides these often complex decisions?
Precisely. The initial management is immediate and critical, often in the emergency department. The primary goal, as soon as the patient presents, is to perform an immediate reduction of the dislocation. This is paramount, not just to alleviate pain, but to prevent further neurovascular injury. Remember, those nerves and vessels are stretched, and to facilitate subsequent imaging by normalizing the anatomy somewhat. Immediate reduction can make a real difference to nerve recovery. Our overarching objective is meticulous restoration of wrist anatomy, paying particular attention to the radial and ulnar styloids, and crucially, restoring the precise length of the attached ligaments. This anatomical restoration confers stability and is directly linked to positive long-term outcomes. Good results are achievable with concentric reduction, treatment of intercarpal injuries, and sound repair of bone and ligament damage.
So immediate reduction first. Is non-operative management ever an option?
Well, for non-operative management, the indications are quite specific and, frankly, limited for true RCFDs. It's typically reserved for patients not medically stable for surgery, or in those exceptionally rare cases where a truly stable radiocarpal joint is achieved after a perfect closed reduction, confirmed by stress imaging. The technique involves longitudinal axial traction, then casting for up to 6 weeks, usually a sugar tongue or long arm cast, allowing ligamentous scarring. While historically some purely ligamentous injuries did okay with this, especially in older, low-demand patients, it's associated with common persistent instability, like ulnar translation and reduced range of motion.
So generally not the first choice for these high-energy injuries.
Generally not. For a high-energy RCFD, non-operative management is almost always considered suboptimal due to the high risk of chronic instability, stiffness, and post-traumatic arthritis.
Which leads us to surgery.
It's exactly. Operative management is widely considered the standard of care for virtually all RCFDs. The main indications are an irreducible dislocation. We can't get it back in place closed, or an unstable joint after attempted closed reduction, where it simply won't stay reduced. The general approach involves open reduction, internal fixation, or RIF, often with radiocarpal pinning and meticulous ligament repair. The goal is stable fixation, allowing early, protected motion.
Okay, let's get onto the surgical techniques. What approaches do you typically use?
When it comes to surgical approaches, we often utilize a volar Henry approach to the distal radius. This offers advantages: nerve decompression if needed, fasciotomy access, direct repair of those crucial volar ligaments, and good access for radial styloid fixation. However, it's often not sufficient alone. A dorsal approach may also be necessary, particularly for dorsal buttress plating or to elevate impacted articular fragments. In fact, a combined volar and dorsal approach is frequently required. Surgeons shouldn't hesitate to make that second dorsal incision for adequate exposure and precise reduction of all fragments. An inadequate approach risks a poor outcome.
Right, do what's needed for full visualization and reduction. What about external fixation?
Provisional stability can be achieved with external fixation. This is incredibly useful acutely for restoring length, controlling an unstable limb, protecting repairs, and allowing early elbow-forearm motion while the wrist is held. It can be provisional before definitive internal fixation, or sometimes definitive immobilization for 4 to 6 weeks in complex cases or those with significant soft tissue injury.
And the internal fixation itself. You mentioned 3 columns earlier.
Yes, a key principle is often 3-column fixation, addressing the radial, intermediate, and ulnar columns. For the radial column, radial styloid, robust fixation is crucial due to that radioscaphocapitate ligament attachment. We might use K-wires, compression screws, or small plates, dorsal, volar, or radial. If it's a small fragment or ligament avulsion, soft tissue repair with suture anchors may be needed. Robust repair here is paramount for stability. The intermediate column, lunate fixation, typically uses interfragmentary screws or tension band wires. Again, suture anchors for ligamentous issues. Anatomical reduction here is critical. Even a 1–2 millimeter step-off risks significant arthritis. The ulnar column, distal ulnar styloid fixation, is more controversial, but indicated for DRUJ injury or persistent instability. This might involve fixing an ulnar styloid fracture, K-wire screw tension band, or TSCC repair. If the DRUJ is dislocated, it needs meticulous reduction and often pinning in mid-supination to maintain it while the TSCC heals. The DRUJ is often the forgotten joint, but instability there is debilitating.
It sounds like addressing all three columns comprehensively is key.
It often is. And ligament repair itself is a cornerstone, often needing magnification. For volar extrinsic ligaments, suture anchors can reattach them. It's critical not to over-tighten, which could limit extension and cause stiffness. We must also evaluate and repair other significant ligaments if disrupted, like the scapholent, leaving that unstable leads to poor outcomes despite good radiocarpal repair. For impacted articular fragments, bone grafting, example from iliac crest, might be needed to restore the joint surface.
And you mentioned nerve decompression earlier, too.
Absolutely. Neurovascular decompression is essential if there are neurological signs pre-op or concern for compartment syndrome. Typically achieved via the Palmer approach with flexor retinaculum release, critical for these high-energy injuries.
That's a powerful combination of techniques, really customizing the approach to the specific injury. It sounds like the emphasis is always on restoring that precise anatomical alignment and stability. However, even with the most meticulous surgical intervention, the journey doesn't end there. What are the common complications we need to anticipate, and what does the post-treatment rehabilitation look like? It sounds like it could be a long road.
You're absolutely right. Surgery is often just the beginning, and vigilant post-treatment care is vital. After operative repair, patients typically undergo immobilization, averaging maybe 5 weeks, range 4 to 8 weeks, often in a splint or cast, depending on surgical stability and soft tissue repair. But even during immobilization, it's crucial to start immediate, gentle, regular movement of all uninvolved joints, shoulder, elbow, fingers, thumb, to reduce swelling and prevent stiffness elsewhere. Early motion is key.
Keeping everything else moving.
Exactly. Once stability allows, usually after pin removal or early radiographic union, critical early hand exercises begin. Simple finger curls, hook fist, tabletop position. For the wrist itself, gentle active and assisted range of motion, flexion, extension, deviation, pronation, supination introduced as soon as safe, avoiding severe discomfort. Move to slight stretch, not pain. Early on, we can begin isometric strengthening contracting muscles without moving the joint. As strength and comfort improve, typically 8–12 weeks post-op, progress to isotonic exercises with light weights or bands, gradually increasing load. Controlled, progressive loading is vital.
Sounds like a carefully staged rehab process. What about potential pitfalls, complications?
Despite best efforts, complications can arise. Acute carpal tunnel syndrome is frequent, especially with delayed presentation or reduction. Persistent or worsening nerve signs often need urgent carpal tunnel release. Stiffness is also highly common, maybe 30–40% loss in wrist motion arc reported. Prolonged immobilization is a risk factor, but also scarring. Treatment involves intensive hand therapy, maybe manipulation under anesthesia, or hardware removal if it's impeding motion.
That's a significant loss of motion, potentially.
It can be. Post-traumatic arthritis is a significant long-term risk, especially with non-anatomic reduction or chronic instability. That articular step-off greater than 2 millimeters is strongly associated with late osteoarthritis. We also need awareness of late intercarpal disruption from occult injuries becoming apparent later. While many neurological deficits resolve after reduction decompression, some may persist, like residual numbness. And non-union or osteonecrosis is a concern for associated scaphoid fractures due to its blood supply and neglected hook of hamate fractures.
A lot to watch out for long-term. What's the overall prognosis typically?
Turning to long-term outcomes, the good news is that with early diagnosis, precise anatomical repair, stable fixation, and good rehab, good functional outcomes can generally be expected. Reviews show promising results. One study reported mean flexion extension arc of 100 degrees, grip strength 86% of the other side. That's excellent given the injury severity. Many patients resume prior occupations, even high-demand ones. However, open injuries and Dumont type 2 injuries historically show less favorable results, often needing more rehab and having higher complication rates. We use outcome scores like Quick Dash, PWRE, to assess function, pain, motion, grip strength. Scores over 65 often considered satisfactory. Interestingly, clinical scores and X-ray changes don't always correlate perfectly with patient-reported function. Someone might have arthritis on X-ray but feel fine functionally, or vice versa.
That's an interesting point about the disconnect sometimes between imaging and function.
It is. And in some refractory cases with persistent instability or severe arthritis, secondary interventions like radiolune fusion or even total wrist fusion might be needed as a salvage procedure later on.
That's a truly comprehensive overview, highlighting both the successes we can aim for and the significant challenges demanding ongoing vigilance. This raises an important question. For our listeners working with these patients, what's the key takeaway, or perhaps a thought to provoke deeper consideration on this challenging topic? What's the one thing you'd want them to carry forward?
For our colleagues, I think the critical importance lies in a thorough, really deep understanding of the wrist anatomy. A judicious, multimodality imaging approach, remembering X-rays, are just the start, and implementing tailored, meticulous surgical strategies. While these injuries are rare and complex, precise diagnosis and rigorous anatomical restoration are absolutely paramount to mitigating those long-term problems like post-traumatic arthritis and chronic instability. It's about restoring not just form, but critical function, and remembering the long game for the patient.
That's a powerful message, thank you. This deep dive has truly laid bare the complexities and the critical pathways for managing these significant wrist injuries. As we move forward in orthopedic practice, perhaps the next frontier lies not just in achieving perfect initial reduction, but in truly understanding the subtle individual biomechanical responses to these high-energy traumas, allowing us to predict and prevent long-term functional impairments with even greater precision. What more can we learn from the patient journey beyond the initial fracture, and how can we leverage emerging technologies to better understand those long-term adaptations? If you found this discussion insightful, please take a moment to rate and share Deep Dive Ortho with your colleagues. It helps us reach more dedicated professionals like yourselves. Thank you again for your invaluable expertise and insights today.
My pleasure entirely. Thank you for having me.
And thank you for joining us on Deep Dive Ortho. We'll be back soon with another exploration into the fascinating world of orthopedics.